Alzheimer's disease. So Alzheimer's used to have an apostrophe S and they took it away. So it's just Alzheimer disease. So don't get confused. But Alzheimer disease is where it's a gradual progression, whereas stroke was sudden in onset, right? Alzheimer is a gradual loss. It's over 3 years, 5 years, like 9 years tops, right? It is a gradual decompensation. It's a neurodegenerative disease. So that means it degenerates. It is going to get worse and worse and worse. And you can see here's a normal brain right here, and here is a Alzheimer's brain. It has literally shrunken, right? It's kind of from the inside out, really. The hippocampus gets affected a lot. Different areas get affected. But fun fact, when you compare an Alzheimer's brain to an alcoholic brain, it looks the same. So life expectancy is about 3 to 10 years, right? And the death is due to complications. You don't die from Alzheimer. You die from the complications of Alzheimer's. So you die from the complications of immobility, whether it be aspiration pneumonia, allostatic pneumonia, a pressure ulcer, whatever it is. They're going to be ending up bedbound. That is the trajectory for them. Okay? So it's not the disease itself, and it's actually the 6th most common cause of death due to Alzheimer-related complications. Okay? 6 million people have it. It's going to triple by 2060. ASCVD is a significant risk factor, so is diabetes and hypertension and obesity. So all those things put you at high risk for Alzheimer's, if not only all the other cardiovascular things, right? So it costs an incredible amount of money to the government. Just in America, it's $215 billion per year. A hospitalized patient is going to stay there for a lot longer than a regular patient. When they come with pneumonia, it's not just regular pneumonia. It's going to be difficult to get them recovered to a place where they need to be. All right. It's the most common cause of dementia. There's different kinds of dementia out there. There's Bruce Willis dementia right there. And there's also Alzheimer's dementia, which is the most common, I think like 60% or so. And then Lewy body dementia is Parkinson's disease, which we'll talk about today. Parkinson's disease is another kind of degenerative dementia that ends up with immobility as an ultimate endpoint. Okay, so who's at risk? Those that are older. 90% of cases are those that are older than age 65. If it's younger than that, it's usually genetic of some sort. What else? Lack of physical activity, being sedentary, a high BMI puts a significant risk for Alzheimer's. Being sleep deprived, that's a problem. Being hearing loss is also, having hearing loss is another problem for developing Alzheimer's. Having a low socioeconomic status, a low education status, and a low cognitive scores will put you at a higher risk of developing Alzheimer's as an adult. So keeping busy, doing more creative things, being smart, these are things, and being able to get a degree and to get a higher paying area, or a more well-to-do area, I would say, a higher socioeconomic status will have a better outcome of not developing Alzheimer's. So these are all things that are protective factors, right? Education, physical activity, cognitive and social activities, having a good brain reserve. So using alcohol is probably not a great idea. It used to be attributed to aluminum foil. It's not. That's been disproven. And then gum disease is a significant risk factor as well for developing Alzheimer's. Okay, so it's neurodegenerative, and these are all the things we can adjust. Like hearing loss, like 8% risk of Alzheimer's. We got smoking, a significant way to develop Alzheimer's, and obviously all the things that cause our ASCVD are going to be risk factors for Alzheimer's as well. All right, so what's going on? So you're making what are called senile plaques and neurofibrillatory tangles. So these things are developing inside the brain because of inflammation, because of a certain protein is thinking it knows how to make proteins. So this protein is designed, this enzyme is designed to cut this protein in half, but it doesn't. It cuts in half, and then all the extra remnants are left over. And these remnants that are left over form an inflammatory process. So it's normally supposed to just cut it nice in half, right there in the middle, and you have a cut in half protein. It's an APP protein, a amyloid precursor protein. It cuts in half, you're great. But what if that enzyme gets denatured, or the enzyme gets inflamed because of obesity, adipokines, or gets inflamed because of atheromas, or inflamed because of smoking, or inflamed because of poor air pollution, good air pollution, I don't know how you would say that, of a lot of air pollution, right? That's going to cause that enzyme not to work great. And you're going to start cutting off at the wrong spot, you're going to start to build up and build up of all these different plaques, or all these different, I should say, what they call beta amyloid plaques. And these things are going to get attacked by our immune system in our brain. And again, what's also under witness protection are white blood cells when they're in different tissues. When a macrophage is usually the one you think of, right? That's in tissues and eats things, right? It eats things and causes inflammation. Well, a macrophage inside the brain is called a microglial cell. A macrophage inside the liver is called a Kupffer cell. A macrophage inside the skin is called a Langerhans cell. A macrophage inside the lungs is called a dendritic cell. It's like, guys, just say it's a macrophage and be done with it. That's hematology for you. All right, so yeah, so we're going to have all this inflammation happen, all these immune responses happen. You get antibodies attacking it. You get all these microglial cells, the macrophages, attacking it, and now you start forming a scar tissue, and this scar tissue is this beta amyloid plaque. All right, so that plaque is left behind, and that plaque is not only inflammatory, but it's also going to start disrupting the internal structure of the neuron, and it disrupts these what we call tau proteins, TAU for tau, and those guys are responsible for making sure the microtubules are good. And the microtubules are basically your infrastructure. It's your lumber or your trusses that hold up the neuron. So the neurons just kind of collapse on themselves, and you get a brain that shrinks, right? So these neurofibrillatory tangles and these senile plaques are what are causing all of this development of degeneration of Alzheimer's, right? So we have all these plaques developing, we form an immune response against it, and that then damages here, damages there, and then inflammation causes the cell to say, you know what, I'm done, I'm out, and apoptosis, right? So apoptosis is cell program death or suicide, right? So that is the idea behind this, okay? So you get decreased acetylcholine as well, like important areas of the brain, like the hippocampus for memory, use acetylcholine, so you lose these things. So our medications are going to be geared towards promoting acetylcholine to help us with memory, right? Helping prevent the breakdown of the hippocampus if possible. So your symptoms, again, they are progressive. They start out just insidious. What's insidious mean? Slow, right? It's like a scary movie called Slow, right? So insidious just means slow onset, right? It happens very, very slow, over 3 to 5 years or so, right? They get forgetful, right? And down here we compare normal aging versus Alzheimer's, right? So Alzheimer's is forgetful, but they forget like important things. Whereas someone who's normal aging, they forget things, but it's just, they'll remember eventually, right? Whereas someone with Alzheimer's, yeah, they're not going to remember it, right? So forgetfulness is not just always Alzheimer's. It's a specific. They can't remember a word for the life of them, just like me. And they have they can't remember numbers. They can't remember concepts. They can't remember certain episodes of the day, or they can't remember what they did in the morning to save their life. But someone like who is older, they might not remember what happened last night, but they can definitely remember what happened in the past. Whereas Alzheimer's, they're going to start losing memories of the past. What happens first, though, is short-term memory loss, right? So they lose what's happening, what happened this morning, what happened an hour ago, what happened yesterday, where they're even at, right? So they have decreased executive function. That's the frontal lobe, right? So they don't have great judgment. They might not act appropriately, but also because of that, they're going to start to get withdrawn. They're not going to interact with the public as much because they realize that they're not, they're not really interacting as well as they could, right? They try to maintain a social facade. They know that they're not acting right, and the MD and us and our family don't really kind of pick up on it exactly. And then eventually they're going to develop what is called anosognosia. They're going to develop where they don't know they have the disease process. So it's kind of like with hallucinations and schizophrenia. A schizophrenic does not know they're schizophrenic. That's just how they act. That's how they are. They don't think they have a disease process. Same things with an Alzheimer's patient. They don't feel they are forgetting things. They don't know. They are not aware that they have a disease. You can tell them, but they're not going to. They're not going to believe it, right? So now we are going to be able to know that, oh, you got Alzheimer's symptoms now, right? You're developing these memory loss things. You're developing these language problems, right? So anomia means you can't, they have problems finding words. And then later they can't even say the word. That's alexia. all right? Or they will just use a different word that's nearby. They'll confabulate things. So they'll tell a story and they'll say all these details and it never happened, all right? But to them, it's true because they don't have a disease and that's what happened. That is what their brain tells them is correct. And then they have agnosia, where they can't process sensory information, right? They don't have concentration. They have attention gets misplaced, or they misplace things. They put their keys in the freezer. They put their umbrella in the toaster. They're putting things in wrong places, right? They might lose their smell as well. The orientation starts getting worse and worse. They're only to start to get oriented at time. They'll get lost, right? They'll be walking out for an afternoon. They come back after 7 p.m. It's like, where were you? And they'll make up a story. I went to Domino's and I met this guy and this happened, that happened, and I got Ubered back. And then you realize, no, you were just in the backyard. What? You didn't go. I said, look, I got Nest now, right? I know where you were the whole time. Okay. And then they start getting neuropsychiatric decline. They start getting mood disorders. They start getting, besides depression, they start getting apathy. They might get aggressive and irritable. They're going to continue to lose all their cognitive function, abstract thinking, judgment. They can't calculate things. They can't do math. Whereas someone who's older, just like a regular older adult, might forget to pay a check, right? But a Alzheimer's patient cannot, balance a checkbook or write a check to save their life. It's not going to happen, right? And then they start getting motor dysfunction, and this obviously is as the end of their process. Right? This is where they might get seizure activity. Now they're bedbound. They have not coordinated movement. They forget how to walk. They forget how to do coordinated movements. They might be a high fall risk, right? Also, we didn't mention up here they're high fall risk because they start to wander as well when they are not oriented to time and such. And then eventually we lead down to immobility, right? Where they're a shell of their older self. They have like no expression because they lost that motor function as well. And they are immobile, bedridden, and really you have like 3 months to live once they are bedridden. All right, so it's a whole progression through. All right, there's a lot of A's that might show up there. All right, it's a deterioration downwards to death. So usually towards the end here, we have to consider what are our goals of care. If grandma gets a pneumonia, what are the interventions we're going to do? If they're bedbound, are we going to do all the aggressive measures, or are we going to, support her, however we can? So diagnostic tests. So there's no confirmatory test. There's like a what's it called? Autopsy, but that's not going to be a valid thing we can do, where you can open up the brain and say, hey, look, there's those amyloid plaques and tau proteins he was talking about. But we just know based on symptoms, right? And the symptoms being, it's like a diagnosis of exclusion. We looked at all of the things. It's not an infection, not a stroke. It's not this, it's not that. It might be Alzheimer's. They're developing all those symptoms we talked about. And we can do what's called a mini mental state, Mini mental state exam, an MMSE. And that will, they do it now and they get a score, and then they do it again in like 6 months to a year, and they can start dropping points, like 3 points each time. And we can validate that. Say, hey, you got like 29 to 30 points right now. You kind of dropped. You drop more. And they can't even do it after a while. And that's if they do it going to regular checkups. We can see that they have a drop in their mental status, right? We had a sitting president who did this and was very proud of this. That's not a valid thing that you should boast about. Like they aren't that difficult to pass. But someone with Alzheimer's, it is a difficult task for them to remember. Okay, so CT MRI, it's going to show a shrinkage of the brain, right? So here's an Alzheimer's brain, all right, it's all shrunk, and because all those microtubule supports are kind of collapsing themselves. So what else? We got a lumbar puncture. We could do a lumbar puncture to find out. We could see some tau protein fragments, but it's not always there. And then there's many neurologic tests we can do. We mentioned the mini mental health state exam. And then what's interesting is when you can associate kind of what their age is. At the beginning, they're just themselves, and they start like turning to a 12-year-old, a 5-year-old, a 1-year-old, a 3-month-old, and then also this is the amount of months they have to live. So you see they have like 5 months to live, maybe a year at the most, when they start becoming speak 5 to 6 words during the day, can no longer talk, can no longer sit up, no longer smile. That's a sign that they are getting worse. Okay. There are 7 stages of Alzheimer's. Usually towards the end there is going to explain these symptoms here. All right, so the Alzheimer's treatment, how do you fix this? All right, so non-pharmacological, what we can do is kind of encourage the things they were doing, like that may have caused it, right? Obviously quit smoking, fix their diet, those things, but low alcohol. But things that actually reduce the amount of neuropsychiatric symptoms and decrease the functional decline that has evidence is that they do enjoyable leisure activities, art, music, whatever they prefer, right? Doing physical activity at will. Make sure they have a good rehab situation where they're reminiscing. They have memory training, doing puzzles and games has shown good outcomes. They have a good sleep schedule, right? We're avoiding sleepless nights. Decreasing ambient noise can be a good way to manage an Alzheimer's patient, and also making sure their way of life is not interrupted, because sometimes we prevent them from experiencing things, right? So here's a
residents of this town have their short-term memory wiped consistently, but they're living their best life. The 152 residents that live here are kind of in an experiment, because this is definitely an unconventional town, but the hope is that it's soon replicated around the world. This is Dementia Village, and as the name implies, everyone here has severe dementia. A common symptom of dementia is the urge to roam, and the way dementia patients are treated in conventional nursing homes doesn't allow that. So a group of Dutch caregivers wanted to change that and launched this village, allowing patients to live the life they once knew. There's only one entrance to this village, which is monitored 24/7, but inside you'll find restaurants, cafes, shops, a grocery store, gardens, and an environment just like the world outside. Residents can roam around as much as they want, and they're treated as normally as possible. The groceries don't have prices, but it still gets scanned, because it's all about creating the environment they previously knew. They're under surveillance at all times by caregivers, but they are wearing ordinary clothes and look just like the other residents. Dementia Village was the first of its kind and launched in 2007, and since then there have been more and more popping up all around the world.
All right, so it's better than nursing home at least, right? They can actually walk around, they can roam, it's a safer environment. All right, so pharmacology-wise, there's none that actually slow the disease progression. Well, that's kind of a misnomer, because now we have a few other agents, these new guys down here, but they are cost prohibitive. It costs like $60,000 per year to be on these medications, and it like reduces like your Alzheimer's by like 20%. It's like, yes, if you have the money, go ahead, go for it. But these other ones are much more achievable, right? Remember we mentioned acetylcholine is for memory, so we're going to potentiate acetylcholine. Acetylcholine gets released in the hippocampus, and we don't want to break it down. We want to keep it around for longer. Acetylcholine is broken down by acetylcholinesterase, an enzyme that breaks down acetylcholine. So we inhibit that with these three guys right here, so DRG. So donepezil, rivastigmine, and galantamine. These are three medications that are used for potentiating acetylcholine. And we have more acetylcholine. Acetylcholine is used at every single gland in the body uses acetylcholine. There's not a gland that doesn't, right? So acetylcholine on your sweat gland will cause you to sweat. Acetylcholine on your salivary gland will cause you to sweat. Acetylcholine on your gut will cause you to defecate or to make more juices, right? So these guys are extremely juicy, or not as juicy as a venous ulcer, but they have, salivation, lacrimation, urination, defecation, GI, vomitation, and emesis, right? So that's the idea with all these acetylcholine promoting drugs. These guys are going to make another debut, our acetylcholinesterase drugs, when we talk about myasthenia. So sludge BB is the mnemonic, right? So we talk about sludge BB is acetylcholine. What is acetylcholine used for in the autonomic nervous system? It's for the parasympathetic, right? So we're going to have bradycardia instead of tachycardia. We're going to have bronchospasm, right? As you learn in respiratory is all about anticholinergics to bronchodilate, right? So these guys are, risk for an asthmatic or COPD. And then we have NMDA receptor antagonists. NMDA is what glutamate binds to. Glutamate is excitatory. It causes seizures. It causes all kinds of destruction. When we talk about ALS, glutamate is the #1 neurotransmitter that's causing destruction of the neurons. So glutamate is not great, so we're going to block that with memantine. Memantine is for memory, right? That is the idea with memantine. It's for severe Alzheimer's disease, and it can kind of help with the symptoms. It does not slow the progression of the disease. It just helps with the symptoms of the disease. And then eventually those symptoms lead to immobility, right? And we kind of talked about immobility already. Immobility is going to have an effect on every single body system: cardiovascular, GI, GU, musculoskeletal, endocrine. Everything's going to start shutting down. We get decubiti, UTIs, pneumonias, we get DVTs, VTEs, PEs, we get heart failure that develops, malnutrition, dehydration, contractures, and now we're back to being bedridden for surezies, right? And these guys all are, as we mentioned with hemorrhagic strokes, they have intracerebral hemorrhage as a high risk factor, because as it shrinks, it pulls the vessels with it and then until they rupture, right? So they have a rupturing of their blood vessels, and that will cause a hemorrhagic stroke. Aspiration, they forget how to eat, right? They have UTIs, not only because of bed rest, but they forget how to wipe, right? So they are high risk for developing these and being bouncing back and forth from a nursing home to a hospital and back and forth, right? So end of life discussion is really a appropriate discussion. It's like, hey, grandma has 5 to 8 months to live. This is, what do you want to do with, or how are we going to progress with her care, right? So that's something to talk about when we talk about end of life in a couple weeks, right? So the idea again is to help reminisce as much as possible, help prevent the neurocognitive decline with different activities we can do during the day.